Linda.
Hello. Let me,
Hello.
I'm going to switch this to start practice session and you guys should be able to stay in. So thank you for joining us for the Illinois Cancer Partnerships Lunch and Learn series on lung cancer. And this is Lung Cancer Awareness Month. So I am Linda Casbeyer. I'm with the Illinois Department of Public Health. I'm the Illinois Comprehensive Cancer Control Program Manager. And I'm going to introduce our host moderator for the session. They're with the Illinois Cancer Partnership Prevention Committee, and they're either the chair and co-chair. We have Sarah Chavez and Eric Adjay. So Sarah, Eric, I'll turn it over to you.
Thank you, Linda. So today we are focusing on the role of early detection and some of the key prevention methods that we can use for preventing and screening for lung cancer. So I will let our first speaker, Michaela Pittman, get started here and let us know a little bit about her presentation.
Thank you so much, Sarah, and thank you for inviting me today to speak. My name is Michaela Pittman. I am the National Manager of Health Promotions at the American Lung Association, as well as the Project Manager for our Illinois Lung Cancer Screening Initiative throughout the state of Illinois. So I will go ahead and get started on some best practices that can be used in lung cancer screening programs, toolkits, and resources. I have no disclosures or conflicts of interest. And I'd like to note that all references to tobacco and tobacco products within this presentation refer to commercial tobacco and nicotine products and not the tobacco and or other plant mixtures grown or harvested and used by American Indians and indigenous people for sacred purposes. So the American Lung Association was founded in 1904 by a group of volunteers dedicated to ending the lung health threat at the time, tuberculosis. The Lung Association and partners prompted the first Surgeon General's report and have helped over 1 million people quit. We are a major backer of smoke-free air laws, and we work to improve tobacco cessation coverage nationwide. With TB largely controlled in the United States, we have since extended that mission to other respiratory diseases such as asthma, lung cancer, and COPD. For more than 119 years, Americans have trusted us to protect their lungs, whether it's researching treatments and cures for lung diseases, keeping kids off tobacco, including e-cigarettes, or advocating for laws to protect the air we all breathe. Our vision is a world free of lung disease, so with this, our goals are big. Defeat lung cancer, champion clean air for all, improve the quality of life for those living with lung disease, and create a tobacco-free future. Each imperative is constructed with the idea that achieving health equity must be the foundation of any lung association goal, objective, or strategy, because when you can't breathe, nothing else matters. So the 2022-2027 Illinois Comprehensive Cancer Control Plan has a series of goals, strategies, and best practices that extend across the entire cancer care continuum, from prevention to screening and early detection, and finally, diagnosis, treatment, and survivorship. Knowing we only have 15 minutes together, and with the understanding that lung cancer is not only the leading cause of cancer death, but lung cancer incidence and mortality rates are higher in males and females and highest in Black Illinoisans, I will be focusing on screening and early detection with the goals to increase cancer screening, reduce late-stage cancer diagnosis, and reduce cancer mortality rates. To inform this section, I'd first like to discuss an integral new project. The Lung Association is supporting and promoting comprehensive lung cancer screening programs and increasing lung cancer screening rates among white and Black men and Black women through the Illinois Lung Cancer Screening Initiative. This initiative works to integrate public health equity best practices through building awareness and reducing barriers to care, increasing early stage cancer diagnosis, and reducing morbidity and mortality rates across the state of Illinois. This project uses client support, quality improvement, and educational objectives in implementation. We've put many best practices in place for this initiative in particular. First, we collect lung cancer screening health system assessments from our partners. This provides our team with an understanding of current health system workflows and programs that are in place, including tobacco cessation integration. And we also collect monthly metrics, which include lung cancer screening, diagnosis, and smoking use status, demographics, and data. These metrics not only allow us to see programmatic successes, but to identify any gaps that may need to be discussed through one-on-one technical assistance. Finally, alongside marketing, we work with our partners to provide patient assistance and culturally relevant tailored resources. In the next few slides, I will highlight 3 topic areas and best practices for enhancement that we address with our initiative partners and would like you all to consider in your work and whether some of these strategies may resonate or support any gaps that you can identify. There are many perceived barriers when it comes to lung cancer screenings. First, many community members don't know what a lung cancer screening is. In fact, only 5.6% of Illinoisans who are eligible have been screened for lung cancer, and lung cancer stigma, healthcare provider implicit bias, trust, and patient and provider education, as well as many other indicators, play a large role in this. And some electronic health records also may not have the capabilities to notify providers of eligible patients, which may also be a contributing factor. However, early detection saves lives, and when we look at the lung cancer burden in Illinois, it's increasingly clear that we need to reach those who are high risk and are a part of historically underserved communities that are less likely to obtain a screening. As many individuals are identified through their primary care physician, some key best practices may include offering continued education to providers and clinicians about USPSTF guidelines, lung cancer screening understanding, and lung cancer prevention, while simultaneously providing educational materials to these providers in clinics where tools can then be put on display in rooms, lobbies, and even given straight to patients in aftercare summaries. We also recommend creating a multidisciplinary approach to identification through numerous specialties, like through breast or colorectal early detection programs, as well as by working with EHR analysts and IT to develop ways to best identify these patients, like a provider-focused EHR automatic notification. We, of course, encourage the development of local relationships and the engagement of local organizations to provide education to underrepresented populations. And in most areas, especially in rural regions, this can include engaging our community health workers. And on that topic, developing patient assistance resources for patients, especially those with financial or transportation barriers who may need further screening and treatment, and providing those resources to providers and clinics so they can best guide those patients. When it comes to tobacco cessation, we often see a lack of tobacco cessation prioritization, staffing capacity, and even a lack of confidence in provider education and decision aids throughout the whole system. And similarly, these conversations can have demographic, geographic, language, or health literacy differences between the patient and provider, leading to tobacco use stigma, healthcare provider implicit bias, and trust. And again, we do see EHR capabilities as a systematic barrier as well. It is important, though, to remember that screening provides multiple opportunities to address tobacco cessation as part of the shared decision-making discussion at the time of the scan or within the results or appointment confirmations. These continued discussions provide further patient motivation to quit using tobacco products while also building patient-provider trust, building key linkages to tobacco cessation programs, and educating individuals on patient assistance opportunities. As for best strategies, the Comprehensive Cancer Control Plan recommends that healthcare professionals undergo training to address cultural competency and reduce implicit bias and stigma. This includes providing culturally relevant media and resources to patients and providers. The Lung Association provides many resources and health equity toolkits to serve diverse communities, including addressing tobacco use in Black communities and addressing tobacco use in Hispanic or Latino communities, to name a few. And healthcare professionals should also be offered trainings like the Lung Association's Gold Standard, Freedom from Smoking Facilitator training, to increase confidence in patient education and support. You'll find a link to our health equity toolkits and Freedom from Smoking landing page on the resources slide later. As with finding eligible patients, work with EHR analysts and IT to not only develop ways to prompt a mandatory screening, but also to collect and document smoking and tobacco use history in a qualitative measure, such as pack your history as outlined by the USPSTF guidelines, rather than through EHR notes. And finally, and arguably most importantly, assess tobacco and smoking use status for every patient, every time, and refer those patients to a cessation program when appropriate. And I know Nancy Martin is a presenter on today's call, so I'll let her go more into depth on tobacco cessation and the Illinois Tobacco Quit Line. Finally, many of our partners within the Illinois Lung Cancer Screening Initiative have expressed difficulty in collecting data on follow-ups after the shared decision-making appointment, the initial scan, and or missed appointments due to the inability to track follow-up through the EHR and a lack of prioritization or staffing capacity. The ways that patients are reminded to return for their annual screening is crucial, and without the appropriate resources, patients can get lost in the system and may not receive encouragement to go back for an annual or even initial scan. Some of the strategies to increase systematic follow-up include confirming and adhering to the cadence for follow-up and follow through to a screening. For our initiative in particular, we recommend a 10 and 30-day follow-up. And these follow-ups can be completed in a variety of ways, including through a follow-up notification to prompt providers or an automatic electronic reminder letter sent directly to a patient. We also highly encourage a certified reminder letter or a personal call to the patient's home to further build that patient-provider trust in ensuring that a reminder has been received. For diagnostic imaging, we would see an adherence to LungRad's recommendations or another structured reporting system to ensure patients understand the results and next steps. But regardless of follow-up type, we do recommend working again with EHR analysts and IT to develop ways to track that follow-up again in a qualitative measure to truly ensure patient follow-through to a screening. And by integrating these follow-up techniques, you're not only increasing your health system lung cancer screening adherence rates, but providing quality care to your patients. From outreach and determining insurance and eligibility through the decision-making and tobacco cessation appointments, and finally the screening and follow-up, I'd like to stress the importance of following patients the entirety of the cancer care continuum. I also want to acknowledge that many best practices were shared today, and then a multifaceted approach to health systems change, whether it is an enhancement to the electronic health record, workflow, or the system structure, often takes time, energy, and dedication, especially as all health systems and clinics work differently. But through quality metrics and education, you can create sustainable change, prioritize best practices, promote health equity, reduce health disparities, and even advocate for further funding to supplement your own programs and outreach. Now, before I move on to some of the resources that we have, I'd like to ask you all to just take some action. When you have some time, take a look at your current health system data, lung cancer screening center or not, and see what patient, tobacco use, or adherence and follow-up demographics and data may or may not exist. Chances are you'll find some numbers that you don't expect and some numbers that you can change. Now, the Comprehensive Cancer Control Plan details the importance of everyone having access to patient navigators. A resource designed specifically for the Illinois Lung Cancer Screening Initiative, the Lung Cancer Helpline provides support to health system patients and community members with barriers to lung cancer screenings, including assistance in determining screening eligibility, scheduling, and locating a screening center, as well as transportation assistance, screening coverage for those who are uninsured, underinsured, or have a high deductible, and free tobacco cessation referrals to the Illinois Tobacco Quit line. Illinois residents can call the Lung Cancer Helpline Monday through Friday, 9 a.m. to 5 p.m. Central Time at 844 ALA Lung. Here you'll find a list of all of our resources that the Lung Association suggests for lung cancer screening programs and health systems. You'll find our Save by the Scan campaign to learn more about lung cancer screening, as well as other lung cancer resources at lung.org and cancer.gov. You can also visit lung.org/USPSTF-toolkit, where you can find information about coverage, billing, and other recommendations. You can find links to programs like our Freedom from Smoking Facilitator training and the Illinois Tobacco Quit line, as well as the Cessation Policy and Health Systems Change Resource Library, and a link to the Illinois Lung Cancer Screening Initiative landing page, where you can order promotional materials and contact the Lung Cancer Helpline. Finally, you can also access our previously mentioned health equity toolkits and partnering webcasts at lung.org/empower your community, and even take it a step further through the final two links by reviewing our Addressing the Stigma of Lung Cancer toolkit and searching for available clinical trials. Finally, yesterday, Tuesday, November 14th, the American Lung Association issued its 6th annual State of the Lung Cancer Report, which reveals that the 5-year lung cancer survival rate for people of color has increased by 17% in the last 2 years. This helps close the health disparity gap nationally. The report further highlights how the toll of lung cancer varies by state and examines key indicators throughout the US, including new cases, survival, early diagnosis, surgical treatment, lack of treatment, and screening rates. I urge you to take a look at this report when you have some time to review the state of lung cancer within Illinois and best inform your work moving forward to increase lung cancer screening, reduce late-stage cancer diagnosis, and reduce cancer mortality rates. Thank you very much. I have included my email here at the bottom if you'd like to get in touch or have any lingering questions or are looking for additional resources after today's call.
Thank you, Michaela. I don't see any questions, so I will ask one. This came up last week. We did talk about it quite a bit. So one of the biggest barriers to lung cancer screening is the fact that you need a PCP, because that has to happen before you can get the screening. And so what happens to people who don't have PCP or don't even have insurance? For example, immigrants who don't have any insurance, how are they supposed to get lung cancer screening? Is there anything that you guys have?
Yeah, that's a great question. And a barrier that we see, I think, across a lot of different health services, due to awareness and other barriers that may exist. The Lung Cancer Helpline, which I've mentioned, will support anyone looking for or even has any questions about their lung health or lung cancer screenings in general. So long as they are a resident to Illinois, they can be eligible to receive some sort of patient assistance to cover the screening, the initial screening in full, regardless of whether or not they have insurance. They will also support in finding a PCP or any health system or clinic near where they live or locally to help them through that process. Our nurse navigator with the Lung Cancer Helpline also does the follow-up through the whole entire process of getting screened through the cancer care continuum. So those patients would never, be left out to sea, so to speak.
All right, thank you. And Linda posted a link to the lung cancer screening. Is that this report? So please check it out. Sarah, you want to move forward?
Yes, thank you, Michaela. This provided just such a good overview of all of these different resources that we have available for lung cancer screening. So our next speakers are going to speak specifically about best practices for community health workers. So today we have Dr. Tracy Smith, who's here on behalf of the Illinois Public Health Association, where she serves as the director of the IPHA Community Health Worker Capacity Building Center. We also have Angela O'Brien, who is here as a faculty at University of Illinois College of Medicine at the Peoria campus. So they will be both speaking about the role of community health workers in empowering communities to combat lung cancer.
Thank you very much, Sarah, and thank you again for having us to share today about something that we're very excited about, which is about how community health workers can help in this space. So Illinois Public Health Association, just so everyone knows, is the oldest and largest public health association in the state of Illinois with a mission to enhance and support public health systems and the practice of public health focused on health equity and improved health throughout Illinois. So lung cancer definitely fits within the space of our mission, really trying to achieve improved outcomes in that space. So if you want to go into the next slide for me, Angela, that'd be great. And we have no conflicts to disclose. We basically want to cover three objectives today, and I'm going to speak for the first 5 minutes and give you a background information on community health workers, because I assume that not everyone knows a lot about community health workers. Then Angela is going to cover an example of a best practice of how to apply the concept of community health workers to the area of lung cancer. So we go on to the next slide. So what is a community health worker? So this is the approved definition through the American Public Health Association. And we would ask that everyone take note of this definition. This is the definition we're trying to get standardized across the state by employers, by organizations, etc. And the key thing here, I think, really supports some of what Michaela was sharing, is that community health workers are trusted members of community. They live in that community typically, they work in that community, they go to church in that community, they walk the streets in that community, they're seen every day. These are trusted individuals. And so very much as Michaela said, that trust is a really critical space when we're talking about getting more individuals in for lung cancer treatments. And really community health workers serve as that link and intermediary between those health social services and the community to facilitate those access to services and improve the quality and cultural competence of service delivery. So again, with many of the best practices that Michaela highlighted, community health workers can be a very integral part of that system redesign to increase lung cancer screening. And it is an evidence-based workforce. There is over 60 years of evidence within the United States in spaces as maternal child health, chronic disease interventions, including many aspects of cancer, immunizations, oral health, HIV, primary care, and many other disciplines. And coming back to the question that was asked earlier about people who don't have primary care providers, this is one of the strong points that we find with community health workers. When they identify people in the community and they start working with them, they have a very high success rate of getting them connected to primary care resources and providers. And so again, we can address a lot of these potential barriers we're seeing in this space of screening by bringing community health workers into this space. And this is a link. On there, we have a link that you can get to that will lay out some of these different evidence programs that are out there in terms of the evidence of their effectiveness. And there's many titles for community health workers currently. So currently in the state of Illinois, we do not have a recognized certification and in the state. So what's happened is that many titles have been applied to who really are community health workers. And so you can see these here. What we are trying to work with, we have established, the state of Illinois through legislation has established a community health worker review board. And one of the goals of this is to standardize that title of community health worker. It is seen by the Department of Labor as a recognized job profession. And so we really want to get organizations utilizing the term community health worker, and then they can subcategorize that. If they're doing outreach or if they're doing navigation, you can subcategorize their work. But please refer to individuals doing this work as community health workers. And this is critical as we move towards certification and billing, because we want to have a standard nomenclature as we work with our billing providers around payment models. So what does someone do as a community health worker? You guys can read this on your own. But what I've already talked about, they link people to primary care providers. They help them to navigate. They help with follow-ups. Again, this is one of those big areas that Michaela brought up. And the community health workers that we're training and working with have a huge role in closing that loop around follow-up screenings and tests and stuff that aren't done. So they can act as a support for the current healthcare system in helping to close those loops around follow-up. There's different models of care for community health workers and how to integrate them into practice. They could be integrated completely into the care delivery team. They could function as navigators. They can function as health education specialist providers. They could function as outreach agents. They could function as organizers. And this is something that we do at IPHA as we work with different organizations interested in bringing community health workers onto their team and into their programs to help you figure out what model works best, what guidelines, what standard operating procedures are needed. And so again, if there's interest on your end and you've not worked with community health workers before, but you're interested in bringing them onto your team, you can reach out to me at my email. And we have a whole program established that we can assist your organization as you continue to build that out.
Okay. I'm going to talk to you today, and I apologize. I forgot to turn my camera on before I shared screen, and now I don't know how to do that. So anyway, my name is Angela O'Brien, and I work with Tracy as a Doctor of Nursing practice student with the University of Illinois College of Nursing. And then I work at the University of Illinois College of Medicine. So I just want to talk to you real quick about the role of community health workers, just to kind of get a little deeper, and then I'm going to share a case study. So we can see that the roles and activities of CHWs are really tailored to meet the unique needs of the communities they serve. So they can be utilized in so many different capacities and upscaled to really be able to provide unique services to different clients in different roles. And the role really depends on such factors as their education, training, or lived experiences. And some really specifically like to work with certain populations. We've even seen like retired nurses or things like that that go into community health worker roles so that they can really focus on a population that they maybe worked with as a nurse. They do not have to be nurses. They do not have to have a formal education. Some roles can include some data collection, meeting with stakeholders, educating healthcare providers about community needs, and then just building connections and really being a conduit to bridge the patients to the healthcare providers. And then there's some other opportunities for them to engage as well. Move on and talk specifically about the lung cancer space. So this next few slides come from a particular article that is linked there. It's also in the reference slide of a case that they looked at in Maine using community health workers for lung cancer specifically. And this particular program focused on the state of Maine because they have a disproportionately high rate of lung cancer there due to about 20% of the Maine residents smoke as opposed to the US average. In 2020 was about 14%. You folks may have an updated number. One of the reasons is because it's very rural and there's barriers to healthcare access, but also they have a very high rate of radon in Maine. So this particular program engaged with community health care workers, and their roles were to do outreach, community education, informal counseling, social support, and advocacy. And they specifically had two aims. One was to increase the knowledge about lung cancer screening. And part of that was because I think Michaela spoke about just people not being familiar with lung cancer screening and really more familiar with breast cancer screening by mammograms and that kind of thing, and don't really understand the low dose CT scans as an option. And then also to increase the number of people referred to the Maine tobacco helpline. So in their first year of efforts, they established a county-wide advisory group to look at the current state of messaging around smoking and lung cancer, as well as the future state, and really took on that nothing about us without us philosophy. They wanted to hear what the community thought about lung cancer and whether or not they thought it was a problem. And then they also assessed local environmental health policy. They introduced themselves to members of the community, and then they disseminated surveys about the knowledge, attitudes, and beliefs around lung cancer. They utilized that survey data then to develop messaging used in their next phases. And then, so that was the first year in the pilot. And then the years 2 and 3, the first year was the gathering, and then the years 2 and 3, they launched the pilot. And they had goals to increase the screening, like I said, and then encourage risk reduction activities such as tobacco cessation or at-home radon testing. Through this program, they were able to reach 1,184 individuals through community health worker outreach. And of that number, more than a third of those patients engaged in some type of risk reduction activity after the pilot. They also had years 3 and 4, which were an annual pilot reminder. So they followed up with patients that were overdue for their annual screening exam, and they actually had really great results with that. And they divided those patients into 2 groups. One group just got a reminder, and another group got a reminder plus a phone call from a CHW. And they saw that patients who received the CHW contact had really impressive numbers compared with those who only received the letter. It was 86% compared to 19. So just kind of summing up, the stakeholders involved here in healthcare are on the screen, and you can see that the community, they all touch the patient, but the community health worker can really be like, I kind of think of them as like an advocate and a bridge. And so they just really are able to work with the patient and then all these other players to be able to see great results. For their particular program in Maine, their final goals and results were just to build individual and community capacity by increasing health knowledge and self-sufficiency. They linked people in their community to services. They motivated behavior change, which you can really see that a trusting relationship with the CHW is key for that. And then ideally, then CHWs would go on to be employed as an extension of the healthcare team. We do have the reference there for that particular case, but then we also have some great resources through Illinois Help Guide Thrive, which is our CHW website. And then we have multiple other lists here. Tracy and my emails are both listed. We do have an IPHA Slack channel for CHWs. If you want to be added to the Slack channel, please contact Tracy about that. And then make sure to check out the virtual toolbox from the Illinois Primary Healthcare Association.
So we
Any
can open it up
questions?
if there's any questions.
Yeah.
Now I can turn my camera on.
Thank you, Dr. Smith and Dr. To be O'Brien.
Thank you. Thank you for that.
Yeah, I really like community health workers. So, in case it's not clear, in head and neck, I work in head and neck cancer, and it's been shown that they play such a big role that now we actually, in my department, we are making an effort in hiring our own community health workers instead of relying on the ones that the institution provides, because they are so stretched thin, but it's been shown and shown how important they are to our patients, especially those that receive surgery. No one they don't understand the surgery they are going to receive. And I don't know if anyone has talked to a surgeon before. Asking a surgeon to explain something in simple terms is a big challenge. So the community health workers play a big role in that. Dr. Smith was graceful enough to make her email available in the chat. So make note of that. Is there any more question? Maybe we will come back after the last presentation. And so I think Laura is online. So Laura will talk to us a little bit about evaluation.
Yes, hello everyone. My name is Laura Houndstein, and I made the same mistake of sharing my screen before turning my camera on, so apologies. But I am part of the Illinois Comprehensive Cancer Control Plan Evaluation Team, and we are inviting you to participate in a brief survey following today's webinar for the purpose of program evaluation and to gather feedback to help plan and improve these webinars. The survey should take 5 minutes or less to complete, and we'll ask you questions about the quality of the webinar and your learning experience today. You can access the survey by scanning the QR code with your phone on this slide, or we'll share the link in the chat. So if you want to click the survey link that will be shared in the chat, we'll share it a few times throughout the webinar. We greatly appreciate your feedback, and your input from this survey is very important to planning and evaluating these webinars. So again, to participate, you can click the link that will be shared in the chat, or by scanning the QR code with your phone or other tablet on this slide. And again, thank you. We greatly appreciate your feedback and time, and look forward to hearing from you.
Thank you, Laura.
Yes, thank you. So our last speaker for today, and then we'll have some time for questions at the end, is Nancy Martin, who is the Senior Manager of the Illinois Tobacco Quit Line. And she will be speaking about our resources here in Missouri, or here in Illinois, for tobacco cessation.
Thank you for inviting me this afternoon to talk about the Illinois Quit Line services. I have no disclosures or conflicts. And as many of you are aware, and thanks to Michaela's presentation, the American Lung Association has been initiating the Illinois Lung Cancer Screening Initiative. Quitting smoking has been shown to decrease the changes of developing the most common forms of lung cancer. Smoking cessation leads to a reduced risk of cancer recurrence in lung cancer, breast cancer, bladder cancer, and gastric cancer. Smoking cessation decreases side effects related to cancer treatment, leads to a better quality of life, and leads to a lower risk of developing another primary cancer. A beneficial aspect of addressing tobacco use in the context of lung cancer screening is that getting individuals to quit smoking at any age can have significant health benefits and decreased mortality, which extends beyond cancer recurrence and cancer mortality. Detecting and curing lung cancer are only part of the solution, as a treatable risk factor exists in many of those enrolled in screening programs. Tobacco use. The Illinois Tobacco Quit Line is a partnership between the Illinois Department of Public Health Tobacco Control Program and the American Lung Association. We work collaboratively with the Illinois Department of Public Health's Tobacco Control Team under the Illinois Tobacco Quit Line Grant. Gail DeVito is the Tobacco Control Program Manager, and Christy Bunn is the Public Health Educator and Regional Tobacco Advisor. The Illinois Tobacco Quit Line was established in 2001, and we have been building partnerships for over 22 years. We're funded through through a grant from the Illinois Department of Public Health from the Tobacco Master Settlement Funds. Tobacco cessation services for all residents in Illinois, assisting with all forms of tobacco, including e-cigarettes and vaping. All residents 13 years of age and older are eligible to receive counseling. Parental permission is no longer required for callers 13 to 17. Building upon American Lung Association's core beliefs about tobacco cessation, everyone can quit. You don't have to quit alone, and one size doesn't fit all. The Illinois Tobacco Quit Line success rates for fiscal year 23 were 19,510 individuals quit. Majority of callers were generated by the CDC tips from the former smokers media campaign. There were 1,840 referrals via eFax and EMR, and we implemented the online process for the that is available on our website. The Illinois Tobacco Quit Line has several options for access. Our telephone number, 866-QUIT-YES. Online enrollment, available 24 hours per day, 7 days per week at www.quityes.org, or online chat is also available on our website. Our operating hours are 7 a.m. to 9 p.m. Monday through Friday, and 9 a.m. to 5 p.m. Saturday and Sunday. Spanish-speaking staff are on site. We have 2 bilingual counselors, and interpretation services are available for over 250 languages. We also have a telecommunication line for individuals that are deaf or hard of hearing. Ask, advise, refer, the role of our healthcare teams. A provider will ask about tobacco use at every visit. A primary health provider or trained staff will advise tobacco users to quit. And then the medical staff will refer any interested clients or patients who are interested in quitting to the Illinois Tobacco Quit Line. Why use Ask, Advise, Refer? It's a proactive approach towards patient health promotion. It follows national recommendations. It determines a patient's smoking status and readiness to quit. It provides support to patients thinking about quitting and who are ready to quit. Nearly 70% of current smokers want to quit. Ask, Advise, Refer has been proven successful. The Illinois Tobacco Quit Line provides referral resources to clients as well as our outreach referral agencies. We identify tobacco cessation resources available within a caller's community. ITQL referral partner background. So what are the benefits of tobacco quit lines? They reach a large number of tobacco users in a cost-efficient way, reduce access barriers to tobacco cessation by providing a toll-free number that is flexible to the caller's schedule, serve as a gateway to other cessation services, such as nicotine replacement therapy, and resources for healthcare providers to refer clients seeking tobacco cessation, and offer a treatment service that is available or appealing to a broad number of clients regardless of race, ethnicity, geographic location, or education level. Studies show that 3 to 5% of people can quit tobacco without any form of assistance. Quit lines double chances of quitting. Quit lines plus nicotine replacement therapy triples chances of quitting. Combination therapy is available per the IDPH NRT distribution guidelines. We offer patches, gums, and lozenges. Going on to our referral partners, there are several ways referral agencies can submit referrals to the Illinois Tobacco Quit Line through a secure email, e-direct referral, which is a coordinated call between the ITQL and the organization's IT team to discuss the integration. It's a very simple process with just a secure web portal link that sits on a staff member's desktop, and it can be electronically sent to the ITQL secure server. We also offer EMR referrals through electronic health records, and it's a bi-directional electronic process for referrals. and I'm happy to provide more information to any agency that is interested in becoming an ITQL referral agency. The ITQL promotional materials, they're all free. We offer such as rack cards, business cards, tear-off pads, tent cards, and downloadable posters. It's all available on our website, quityes.org. Material order forms can be submitted via email, info@quityes.org, and via our website. Right now, it's under construction, I guess was a good way. We are relaunching our website. It's brand new. In phase 2, this option will be available again. But if you need any kind of free promotional material, please reach out to info@quityes.org or my personal email. I'll be happy to make sure your order gets completed. And just to introduce you to our new logo and our new branding and material, this is our new logo. It's Your Quit, Your Call, and it's funded by the Illinois Department of Public Health, of course. And my contact information is nancy.martin@lung.org if you have any questions, or if I can provide any information about becoming an ITQL referral agency, or if you need free material. Thank you so much for your time today.
Thank you so much. So we've been monitoring the chat, and I think the only question we had was regarding the slides to be shared after the presentation.
Yeah. So please, if you have any question, post it in the chat, or I think you can unmute yourself and also ask it if you want to. So I'll ask one as we wait for others to. So there's this idea that almost no smoking cessation program works. So when you talk to physicians, that's the first thing they tell you is, oh, what smoking cessation program do you know that has worked over the long times? Usually it will work for a while, and then because I think one of the issues is most of them are done through grants. So as the grant is going, it works, and then once the grant finishes, then everybody kind of forget about the participants. And so then they go back because of peer pressure and all kinds of things. So what advice do you have for physicians who are going to push back on smoking cessation? And this can be for probably all of you, not just Tracy.
So I was just gonna say, what I've really found is, it is a multifactorial space of the reasons for smoking and the processes. So I think much as what was just shared was combining multiple approaches together is very powerful, right? And increases the success rate there. And so I think that's where CHWs are really important too, is that they can help to address some of those other underlying things that may actually guide people back to potentially smoking, other stresses in their life, helping them to alleviate some of those other crises that they may be living in, which can come back and cause a lot of problems. So that relationship with CHWs and addressing those social determinants of health, those histories of trauma, and then utilizing a lot of the great the Tobacco Quit line and the American Lung Association information and support pieces out there, bringing all those together, I think is where you really start to be able to address those concerns from providers that this is not just a one-time over. This takes a team. And I think that's the exciting thing that I think all of us are really sharing today, is that we're building that team out.
I would also like to add on to that as well. And I know I touched on it probably quite a few times when I was speaking, but the importance of enhancing EHR systems to work to be able, for providers to be able to screen and assess smoking and tobacco use when they're with the patient every time. And those other opportunities along the cancer care continuum to be able to do that. And when it's integrated into an EHR system, well, if it's prompted and it's mandatory, it needs to happen. And I know it does take time and often takes money, but that's where those quality metrics that I've touched on really come in handy. Having those quality metrics and going to a funder and saying, hey, we want to be able to do this for our EHR because we know that, you know, these many people are using tobacco products, and this is what they've reported to us. Being able to share those resources to the right people who will be able to move forward with creating that sustainable change that moves past a grant cycle, and whatever program that they may be involved with. It becomes a little bit more sustainable long term, and then creates that change among providers as well.
Another thing I wanted to add, I really think is important, just much as you're talking about like the EHR system, is having a space for early identification of the potential for relapse, or where people are facing a crisis that may make them to relapse in that space. And so again, whether that's a CHW being able to document in the EHR and saying, we need to call your provider, you need to get in there to see and talk to them about, you know, your drive to want to smoke again, or that you've started to smoke, and let's catch that early on before months and years go by again, that they get asked that question. So very much like you're saying, Michaela, that frequent assessment, is it still working? Are you still in that space of being able to not smoke? How's that feeling for you? Is there new stressors coming up that may be pushing you back to that practice to deal with that stress? Those types of things I think are really critical questions that providers need to think about.
Yeah, I think those are very important. And then I know there was a little bit of talk about stigma. Could you talk a little bit more about it? Because it's so true that stigma plays a big role. So most patients will even lie that they smoke because the doctor is going to judge them that they got head and neck cancer or lung cancer because they smoke.
Yeah, I can kind of take the head start there. I think, you know, stigma is huge, I think, in a lot of different areas. It's not just healthcare, and a lot of that is very historical. And I think when you start talking to providers, or clinics about some of the barriers that they see, whether it is staffing capacity or prioritization of, you know, assessing tobacco use or screening or whatever it may be, you know, a lot of that I think can be supported by, you know, appropriate training and annual training that addresses the stigma that is, you know, surrounds lung cancer, but also surrounds tobacco and smoking, and that dual stigma that exists. And also the education around lung cancer. It is treatable. You know, it is something that, getting a screening will, you know, it increases your likelihood of, you know, survival by 20%. So really having those open-ended conversations with your patient, through that shared decision making, and having that education that really is tailored towards cultural competency and that stigma and that bias, even that level of awareness, raising that among providers is huge, and it can go a very, very long way. But I know I see Tracy shaking, you know, nodding her head, and I'm sure she probably has things to add. But yeah, I think it again, it's a whole disciplinary approach too. It can't just be one person going through these education modules, and it needs to be everyone who's a part of our health systems.
I wanted to just add to that. I really think that as we've done more training for healthcare providers in the spaces of implicit bias and trauma-informed care, highlighting how those components are really critical to apply to those conversations about cessation. Whether that is smoking, whether that's alcohol use, whether that's drug use, whether that's whatever, right? Our nutrition and physical activity, all of those spaces have sometimes very similar roots. And I think the important thing for us is to figure out why. What's the root to why you smoke, right? And giving people back the power to say, I don't have to smoke to deal with that stress or that anxiety. I have the power to control this some other way. Especially if we're looking at a trauma-informed approach, we really find out that people feel powerless when they've had certain experiences that have led to trauma that has affected the way that the different parts of the brain interact together to help you see a certain circumstance. So I really think that if we can do more training and really have those root discussions and get comfortable talking with folks about what's the root cause of this. But I think also part of that is a lot of times providers, you don't have the answers to those things. So let's say a patient says, I smoke because I'm really stressed about my housing, right? Everything in my life is I don't have food, I don't have housing, I don't have all these things. And as a provider, you're like, what do I do, right? You know, I've been in that space too. But that's where then having that team that can help say, okay, boy, housing, I understand why you're stressed here and why you would want to smoke. That helps you to decrease your anxiety. But let's address this housing in a way that's not going to harm your health, right? And you have the power to control this space. And so I think bringing back all those motivational interviewings, giving people back power, letting them know that sometimes the behaviors they do is not the choices they made, but what's been done to them in life, and help them to relook at that in a different perspective really helps us to heal and get to a place where some of these different behaviors we have don't have to be the answer for people.
See any more questions? So I don't see Christina posted a link to resources addressing stigma in lung cancer patients, so please check it out. Any more questions from anyone? I take that to be a no. So I would like to thank our presenters. And this is the last and third series of the smoking cessation seminar. So thank you all for attending, all three of them, especially those of you that were able to do so. And please don't forget to complete the evaluation so we can use it to make these better going forward.